Hello, everyone. Thank you for attending our webinar. We'll be waiting just a few moments longer to have more people sign on, so thank you so much for your patience. Hello, everyone. For those who just came on, this is just a quickly note that we will be beginning shortly. Thanks for your patience. Okay, welcome. I think we're ready to begin. But firstly, I'd just like to ensure that everyone can hear me. So if you can, if you could please type yes into the chat box, which you'll find on the left-hand side of your screen. Perfect. Okay, great. I'm seeing lots of pop-up messages. Thank you so much. That's great. So welcome to Asthma Canada's Severe Asthma Charter Series webinar on severe asthma in children. Our 2020 webinar series has been made possible through educational grants from AstraZeneca, Novartis, GSK, and Sanofi Genzyme. Today, we'll be speaking about severe asthma in children. This is an incredibly important topic for Asthma Canada and our community, and I know many of you have been looking forward to this, so thank you so much for joining us. My name is Kristen Balwa, and I'm the Manager of Communications, Programs, and Public Engagement at Asthma Canada, and I'll be your moderator today. So before we begin, I'd just like to go over a couple quick points. This webinar is being recorded and it'll be uploaded to our website shortly, so please do feel free to share it within your networks. All attendees are muted, but at any point if you have questions, comments, issues, etc., please type into the chat box, which I'll be monitoring throughout. There's a little blue question mark at the top of your screen, and you can also type your questions there. There will be a Q&A at the end, but please make sure to type any questions in as we move throughout the presentation. So very quickly, I'd just like to highlight some of our work. Asthma Canada is the only national organization solely dedicated to helping all Canadians affected by asthma. At the heart of all we do is our vision to empower every child and adult with asthma in Canada to live an active and symptom-free life. We're committed to improving the lives of the Canadian asthma community through education and support services, advocacy, and research. We encourage self-management by helping our community take control of their symptoms. And we do this through our educational resources and services like our Asthma and Allergy Helpline, and through our webinar series like this one. We're also committed to bringing your voice to the forefront of policy decisions that affect our community, advocating on important issues like sustainable clean air and energy, choice and access to treatments, and access to medication in schools. And of course, Asthma Canada supports research into better health outcomes and the eventual cure for asthma. We have a national national research program, which supports graduate level students studying early or late onset asthma. We actually just announced the 2020 winners this week, so feel free to visit asthma.ca for more information. And much of the work we do is through our community of volunteers and members across the country. People living with asthma, their families, parents, caregivers, healthcare professionals, educators, and others who are strongly committed to improving asthma care and quality of life. The Asthma Canada Member Alliance is a free membership of Canadians who engage in all the work we do and provide support and input into our initiatives. So if you haven't done so already, I would welcome you to join us. And now I'd like to introduce our distinguished presenter, Dr. Thanuka Radhakrishnan. Dr. Thanuka Radhakrishnan was appointed to the Department of Pediatrics at Western University in London, Ontario in 2010, and led the development of a multidisciplinary pediatric asthma program at the Children's Hospital London Health Sciences Centre. She joined the Children's Hospital of Eastern Ontario and the University of Ottawa in 2015, where she is the director of the CHEO asthma program. Her clinical interests include the care of children with airways diseases, including asthma and cystic fibrosis. She leads projects through the Lung Health Foundation in Ontario and the Canadian Thoracic Society, and has developed guidelines, workshops, and knowledge translation tools to improve care providers' ability to manage childhood asthma. Dr. Radhakrishnan's research involves the use of health administrative data at the Institute for Clinical Evaluative Sciences to investigate the incidences, risk factors, and outcomes of children with asthma and other respiratory diseases. So thank you so much for being with us today, and I'm happy to pass the presentation over to you.
Great. Thank you so much, Kristen, for that introduction. And I'd like to thank the listeners and viewers. I don't really know how to call the audience of a webinar, but all of you for joining in this afternoon to hear a little bit more about severe asthma in children. The objectives for this talk today are so that everyone listening would be able to develop an awareness of what is severe asthma in children and the steps to diagnose it, to understand the approach for treatment of severe asthma, to understand the risks and benefits of different medical treatments for severe asthma. And I will just pause because I didn't double check if everyone can hear me as well. Kristen, please let me know if there's a problem. So moving on to the burden of asthma in our society, specifically in Canada, really. Asthma is the leading cause of hospitalizations in Canada. And severe asthma affects up to 5% of all those people who have asthma. Now, as far as healthcare costs related to asthma, 50% of those are attributable to the population of people who have severe asthma. And in general, patients tend to underestimate the severity of their own asthma and overestimate their level of asthma control. So this estimation of 5% may even be an underestimate. Now, why is this a problem? Well, severe asthma can lead to airway remodeling and permanent reduction in lung function. So there can be long-term consequences of childhood severe asthma. Severe asthma is also associated with impaired quality of life, and unfortunately, even today, sometimes death. Approximately 345,000 people were reported to have had an asthma-related death in the world in the year 2010, and that figure has not really changed in the last decade. Each year in Canada, we estimate that about 250 people die of asthma. And the unfortunate thing, again, is that these deaths are largely preventable, particularly if we had improved management of patients and increased access to specialist care, specifically for people with severe asthma. So in response to this burden of illness and the fact that unfortunately people still die of this disease, a group came together to develop this charter to improve patient care in severe asthma. And this charter consists of 6 guiding principles that aim to address the unmet need and burden in severe asthma, to raise awareness and understanding about the substantial impact of severe asthma, and to create opportunities for improving patient care. Now, I'll just pause by mentioning that this charter was funded through AstraZeneca. And so, there could be opportunity or thought for, is this really truly reflective of what's happening in our society as far as asthma and what we should really be aiming for as far as severe asthma? But in fact, the items that are listed in this patient charter have been validated and agreed upon by many other organizations as well. So I stand behind them, and I'll declare that for you today. So, what are the principles listed in this asthma charter? The first is, and they're pretty small here, so I'll read them out for you. Principle one, spoken from the perspective of someone with severe asthma. I deserve a timely, straightforward referral when my severe asthma cannot be managed in primary care. Principle two, I deserve a timely, formal diagnosis of my severe asthma by an expert team. Three, I deserve support to understand my type of severe asthma. Four, I deserve care that reduces the impact of severe asthma on my daily life and improves my overall quality of care. Five, I deserve not to be reliant on oral corticosteroids. And six, I deserve access to consistent quality care regardless of where I live or where I choose to access it. Now, today, of these six principles, I'm going to be focusing on four of them really, and these are a timely, straightforward referral, a timely, formal diagnosis, understanding my type of asthma, and deserving not to be reliant on oral corticosteroids. So for the first, I deserve a timely, straightforward referral. What does this mean, and what have we done about this? Well, I will proudly speak that at least in Ontario, and I suspect very shortly across the country, we have developed some quality standards for how asthma should be managed at the primary care level. We developed 6 statements that were just published in September 2020 to describe what quality in asthma care looks like. And this set of quality standards includes definitions, as well as a guide for patients and families, and looks something like this, with the website where these standards can be accessed listed at the bottom of the screen there. But certainly if you just apply Asthma Quality Standards Ontario in a search engine, you'd be able to find them. And why I'm proud of this is because, again, it aligns with this charter for severe asthma, and very specifically states, as far as referral to specialized pediatric asthma care, that children and adolescents with asthma with appropriate indications are referred to specialized pediatric asthma care. I think this is extremely important, in particular for very young children, preschool children, but certainly also for older children and adolescents, that it's important to recognize when people with more experience in managing severe asthma are brought into the care of the child, or should be brought into the care of the child. So what are these appropriate indications for referral? They would include the following. If there's an inability to complete lung function testing for the patient, especially for patients 6 and older who we believe are able to perform lung function testing reliably, we really recommend that asthma should be diagnosed objectively using lung function testing. If there is diagnostic uncertainty, maybe there are other clinical symptoms or features that make it unclear whether the child truly has asthma or some other diagnosis. If the child has had lung function testing performed, and even if they have good symptom control, if the lung function is abnormal and persistently abnormal despite use of asthma treatment, that child deserves referral. If there is suspected comorbidity or an alternative diagnosis, if there's been lack of response to an escalation of controller medication, so symptoms are still not well controlled, even though the dose of controller medication is being increased. If there are repeated exacerbations requiring oral corticosteroids, emergency department visit, or hospitalization, and I would highlight this is probably one of the most important ones, and I would say the least well-used indication for referral. Oftentimes we see in our clinics, and I've worked at a few different severe asthma clinics, patients who have had several emergency department visits before they came to the attention of a specialist, and this is probably later than we would like. We'd like these children to be recognized and referred sooner. And finally, if there's suspicion or recognition of severe asthma. So, moving on to the second principle I wanted to address, I deserve a timely formal diagnosis. And of course, all of these are linked to some degree. But how do we diagnose asthma in children? In principle, we identify this diagnosis if there are compatible clinical symptoms, if there is a reversibility of symptoms on objective testing, so that's the lung function testing I was talking about, or with the use of asthma medications. And that second part, asthma medications being involved in diagnosing asthma, is really most applicable to the preschool age group when it's difficult to perform lung function testing. So, if there's compatible symptoms, reversibility, and finally, lack of red flags for an alternative diagnosis, we would feel fairly comfortable that this child, in fact, has a diagnosis of asthma. But how is severe asthma different? So, this requires us to take a step back and think about what really is asthma. Well, it's defined in our Canadian Thoracic Society guidelines and in our Global Initiative for Asthma and many other guidelines around the world as a disorder of reversible airways hyperreactivity plus airways inflammation. And this results in chronic or intermittent episodes of wheeze, shortness of breath, chest tightness, cough, usually at night or early in the morning. Episodes are triggered by allergens, irritants, or viruses. So this is the syndrome, the condition, the disease that we call asthma. Now, within asthma, there's this concept of uncontrolled asthma. And I will say that uncontrolled asthma and severe asthma actually are not the same thing. And I'll illustrate that here. So if we have a population of people, of children who have asthma, within that population, about 50% of them probably are uncontrolled. And that means that they have poor symptom control, frequent and severe exacerbations, or serious exacerbations, and they have limitation in their airflow. So, a forced expiratory volume of less than 80% of their personal best, or less than the lower limit of normal. So, within the population of people with uncontrolled asthma, we could in fact have some who have mild asthma but just haven't been diagnosed or treated or started on control or medication, so their symptoms are out of control. And we could have people with moderate asthma. And it turns out that severe asthma represents 5% of this total population. And severe asthma, just like mild and moderate, could be controlled or uncontrolled, depending on whether it's been diagnosed and treated adequately. And just to reiterate this concept of acceptable asthma control, this has been fairly well defined, though the definition keeps evolving, and we've made some nuances with respect to age of the child. But in a nutshell, acceptable asthma control means that daytime symptoms happen less than 4 days per week. And in the preschool age group, we actually aim for less than 2 days a week. Nighttime symptoms are happening less than 1 night per week. Physical activity is unrestricted. It's normal. And this is an important question to ask families or to ask yourself if you are someone with asthma or have a child with asthma. Have you imposed or has the family imposed restrictions on physical activity so it seems like the child doesn't have symptoms, but actually they're not living a full life? And that's a question that we need to ask carefully. Use of a rapid acting bronchodilator should be happening less than 4 times a week, or again in the preschool age group, probably even less than 2 times per week. Exacerbations should be mild, infrequent, and certainly no more than once a year if they're requiring oral corticosteroids. And the child should be able to attend school or preschool or childcare without missing days due to asthma symptoms. So this is the goal that we're trying to achieve. Now, coming back to this concept of severe asthma and how do we diagnose it, our Canadian Thoracic Society published a position statement in 2017 to outline the process for diagnosis and also outline concepts in management. And there have been some progress, actually, even since 2017. Our field of management of severe asthma, even in children, is rapidly exploding over the last couple of years, and it's quite exciting. But what does these guidelines say? Well, they define severe asthma as asthma which over the previous year required treatment with high dose inhaled corticosteroids and a second controller, or systemic corticosteroids, for example, oral prednisone, for more than 50% of the time. So, when we're talking about high dose inhaled corticosteroids, we need to know what low and medium doses are. And these guidelines do include this particular dosing table, which is divided into the pediatric age group, 6 to 11 years of age, as well as adolescents and adults, 12 years of age and over. And I've indicated with the red boxes what the high dose categories are, and they're fairly similar between the pediatric and the adolescent and adult age groups. But where the trick comes in is for this preschool age group. And you might notice through this talk, my bias is that I focus on preschool asthma. So I do bring it up as a separate concept when I can. But very young children, the dose of medication that's required to keep symptoms in control, high dose is quite a bit lower than what we would usually think about as being high dose. So it actually is half of what would be considered high dose in older children and in adolescents and adults. So just to give an example here, fluticasone anywhere above 250 micrograms per day in total would be considered high dose for a child 5 years of age or under. So getting to more granular level, how do we diagnose severe asthma? So the steps that we would take if a child were referred to us and in general across the country would be to first confirm the diagnosis of asthma, ideally using objective testing if this has not been done already and documented properly. But once the diagnosis, in fact, is confirmed, we would then ensure that asthma treatment has truly been optimized. And this would entail optimizing the dose of medication that the child is on, addressing adherence and ensuring that the child is truly taking the medication as often as prescribed, which usually means every day and in most cases twice a day. And also that the child is using the appropriate technique for use of the medication, perhaps using a valved holding chamber or whichever device has been prescribed, that it's being used properly. We would then look at treatment of comorbidities. Many children and patients with asthma can have additional conditions that make their asthma worse. So, for example, gastroesophageal reflux disease, allergic rhinitis or sinusitis. Vocal cord dysfunction is a little more rare, but it can certainly make things more complicated to treat. And psychiatric disease, specifically anxiety. Anxiety symptoms can exacerbate asthma, can be confused with asthma. So it's important to tease out that complicated relationship in order to achieve control. And finally, we would take steps to rule out an alternative diagnosis. And it's thought that up to a third of individuals who are thought to have asthma, specifically severe asthma or treatment resistant asthma, in fact may have an entirely different diagnosis, for example, cystic fibrosis or even a heart condition. And that sometimes requires specialist evaluation to figure out. Identifying an alternative diagnosis may require additional testing that's not always present or available in primary care and could involve more complex imaging, for example, CT scans, video fluoroscopy, perhaps an evaluation by an ear, nose, and throat specialist to look at the vocal cords, or even bronchoscopy, which is looking directly into the airways to see if there are other diagnoses that are affecting the child. So once we've done all of that, what else are the differences in severe asthma? So going back to the patient charter, the third point was, as a person with severe asthma, I deserve support to understand my type of severe asthma. So what is really meant by that? Well, in fact, severe asthma is a variable disease with different subtypes. And these subtypes can be called phenotypes or endotypes. Different words are used and they mean slightly different things, but for our purposes, we'll just call them subtypes. And identifying which subtype is useful because it can predict a patient's response to targeted treatments and allow for patient-tailored medicine. So asthma phenotyping involves something called biomarkers. And I'll just take a step back and say that there are generally two types of inflammation present in asthma, and we call them two different types of asthma. Th2 inflammation, and Th1 inflammation. And these labels speak to different types of white blood cells and other immune molecules that are present in the airways and the lungs of someone with asthma. Th2 pathway means certain types of molecules or biomarkers are produced. For example, IgE stands for immunoglobulin E, and certain cytokines, specifically IL-4, which stands for interleukin 4, interleukin 5, interleukin 13. And these are all now targets for new asthma therapies, and we're going to talk about this in much more detail. The biomarkers that we can measure, we actually can't measure IL-4, IL-5, and IL-13 in patient care yet, perhaps in future. But what we can measure is whether or not the patient has allergy, so aeroallergen sensitization. And we ask for the help usually of our allergists to identify whether the child has skin prick test sensitivity or serum sensitization to aeroallergens. We can measure their level of immunoglobulin E or IgE, and this would predict the patient's response to anti-IgE medications. And we can measure the level of eosinophils in their serum or in their blood. Eosinophils are a specific type of white blood cell and tend to be increased and activated in people with allergic asthma. And if someone has elevated eosinophils, this would predict a response to certain types of anti-IgE and IL-5 medications. And again, we'll talk about this in more detail in a few minutes. There are a few other biomarkers that are more difficult to measure in children, and in fact, generally are not available, but they are measured in adults in academic centers and may be coming to use in children over time. And this would be eosinophils, or that special type of white blood cell in the sputum of patients, and something called fractional exhaled nitric oxide, which provides a measure of allergic inflammation in the airways. So let's try and simplify this a little bit. What am I talking about with all these numbers and letters and all this jargon? So this is a picture or a schematic that I grabbed off the internet, but is something that probably most of you have seen. And it's a picture of the lungs in the middle with the main airway or trachea dividing into the right side and into the left side, and then dividing into millions of teeny, tiny little branches that we call bronchioles or airways. And on the left of your screen, you see a picture of a normal airway where there's a nice, wide, open diameter for air to move in and out. And on the right, you see a picture or a schematic of a airway of someone with asthma where there's inflammation, there's thickening and contraction of the muscle, and there's mucus production in the airway, making the diameter for air to move in and out much smaller. And this gives rise to all the symptoms of asthma. Now, if we flip that asthma airway on its side, standing it upright, and then simplify this a little bit, I'm just showing you two rows of respiratory epithelial cells or airway cells. And this is going to help us understand all the different inflammation present in people with asthma. So this is that same picture with a few other blue blobs and purple blobs and things added in, and I'm going to explain all of this. So those pinkish oranges cube type cells are the airway cells in every person. And we all also have a special type of airway cell called a goblet cell, which I've pictured in pink here. But then we have all kinds of white blood cells that just hang out in our airways. And if you're someone with asthma and you have inflammation, there will be a higher number and higher variety of these airway white blood cells. We have the purple ones are Th1 and Th2 cells. If you recall, I talked about two different types of inflammation in people with asthma. And then these pink and blue ones I'll explain momentarily. So if we start off with our Th2 pathway of inflammation or our Th2 white blood cells, one of the things that they can do, if there are enough of them present and they are stimulated or triggered, they can then stimulate or trigger a group of white blood cells, as I mentioned before, called eosinophils. Now, eosinophils are useful in human beings. They're an important part of our immune system, but when it comes to asthma, they're the bad guy. And eosinophils produce these molecules, these interleukins that I mentioned, IL-5, IL-4, and IL-13. These molecules cause inflammation, they activate more eosinophils, which cause more inflammation. And this is a major pathway driving inflammation in people with asthma. Now, the other thing that Th2 cells can do is stimulate the production of immunoglobulin E, or IgE, and this is our main allergic antibody. And IgE antibodies can attach onto a special type of white blood cell called a mast cell, which are present in the airways of people and can get activated in the setting of asthma. And when activated, these cells produce a substance called histamine, which also gives rise to inflammation. And finally, the Th1 pathway, and I've simplified it quite a bit here, just to say that when Th1 cells are activated, they would stimulate different types of white blood cells altogether, neutrophils, granulocytes, you may have heard those words, and those can give rise to inflammation as well. So the final common pathway for all of these processes is the development of inflammation. Now, we already have a very good treatment for inflammation, and the name of that treatment is corticosteroids. And we can administer corticosteroids either inhaled, or if there's a lot of inflammation present, we provide corticosteroids in a systemic fashion, either oral or even IV, but usually orally in the form of medicines like prednisone or dexamethasone. And these medicines are very, very good at reducing inflammation. However, one of the principles on the asthma charter is I deserve not to be reliant on oral corticosteroids. Well, if there's such a good medication, then why not? Well, the truth is that oral corticosteroids, as opposed to low and medium dose of inhaled corticosteroids, high doses of inhaled or oral corticosteroids can give rise to a whole host of side effects. And specifically for oral corticosteroids, because we're dealing with very high doses, these would include things like osteopenia, which is thinning of the bones, osteoporosis and fractures, high blood pressure, diabetes, something called avascular necrosis, which can lead to loss of hip function, adrenal suppression, muscle weakness, and then other side effects, which perhaps to the physician are not as important, but to patients and families, they certainly are. And this would include impaired growth and height, mood instability, appetite stimulation, which can lead to weight gain. And for teenagers, acne can be a huge, huge important side effect. So how do we then identify medicines other than oral corticosteroids for people with severe asthma? What I've thrown up here on this slide is, again, the Canadian Thoracic Society guidelines that have a figure in them, which is the approach to treatment of people with asthma. And at the very top, in very tiny print, you see this red triangle. And that red triangle represents severe asthma. And if I continue on to expand that, this is that red triangle made quite a bit bigger. And actually, there's a fair bit of detail within that triangle now, since 2017 at least. And there's all kinds of other treatment options that can be considered in addition or instead of oral prednisone therapy or oral steroid therapy. And these would include medications such as omalizumab, antibiotics such as macrolides, anti-IL-5 therapy, tiotropium, as well as assessing the asthma phenotype to figure out which of these other treatments may be an option for the patient. And I'm going to go through each of these now to finish up the last part of the talk here. So starting with tiotropium, what is this? So this is a fairly new treatment in asthma. It's been around more than 5 years, but not much longer than that. It is a long-acting muscarinic antagonist, and that's certainly a mouthful. But the short form of this is LAMA. It's a type of medication that's been used in a different kind of respiratory condition called COPD. But more recently, we've identified that it may be useful, and in fact, it can really be useful in people with severe asthma. This medication can cause bronchodilation, so the opposite of bronchospasm, but actually relax the muscle in the airways, allow them to open up. And it can reduce mucus production at the level of the goblet mucus cell, if you remember that pink cell that I showed you in the diagram before. This medication is administered once a day, and it's approved for use in children 12 years and older, but in the United States, it's even approved for children 6 years and older. It's provided in a very easy to administer inhaled format, and it is intended to be used not as monotherapy, so not on its own, but in addition to regular controller therapy. And our clinical trials have shown it to have a significant improvement in lung function and reduced exacerbations, probably, though this outcome is a little bit less clear and will require a little more experience and more study for us to really know what the effect on exacerbations is. However, the medication can have side effects, including dry mouth, dilation of the pupils, which can affect vision in certain circumstances, urinary retention, metallic taste. Usually, these side effects are minimal, as at least in my experience, but they require the patient to be well monitored to make sure these are not a problem. So that's one type of medicine. Another type of medicine is macrolides. So this is a class of antibiotics that have anti-inflammatory or neutrophilic effects. So these medications could be used in people with the Th1 type of inflammation or that subtype of asthma. Use of macrolides in adult studies have been shown to have some improvement in asthma control and some reduction in exacerbations in adults. But their effectiveness in children remains to be seen. We don't quite know if they're effective or not, but on a case-by-case basis, they could be tried. Potential side effects would include something called prolonged QT, which affects the rhythm of the heart in susceptible patients. So it's important to get a screening electrocardiogram done prior to starting this medication. Can result in diarrhea, as many antibiotics do. And when we're using an antibiotic long term, we always have to think about resistance of bacteria to that antibiotic. So for the case of macrolides, there's a specific bacteria called non-tuberculous mycobacteria, and it would be important to ideally test whether the patient has this bacteria before starting this antibiotic to know that we're not causing harm and causing antibiotic resistance. Another class of treatment we can use is immunotherapy, and this could be a talk completely on its own, and I'm not going to do it justice here, but just to touch on individuals who have allergic asthma, and if they've been shown to have sensitization to allergens in the environment through skin prick testing or serum testing, which our allergy colleagues can help us with, may qualify for immunotherapy, which is typically administered as a monthly subcutaneous injection. But there are new oral immunotherapy medications being developed, some of which are available for children 6 and older, and may help to treat some of the symptoms associated with asthma and improve asthma control in children who have a lot of inhaled allergies as well. So the last class I wanted to talk about of medications are biologic therapies. And are these now an option for children? Well, the short answer is yes, but what are they? Biologic therapies are treatments directed against specific asthma inflammatory biomarkers. They are administered by repeated subcutaneous injection. And the one that we have the most experience with is omalizumab, or Xolair as a trade name. The target of this medication is those IgE antibodies, which I've pulled up the image here again for you if you recall. IgE antibodies bind onto mast cells and cause inflammation, but omalizumab stops that process so that there's reduced inflammation and reduced histamine release. And this class of medication can be quite effective for reducing asthma exacerbations, which is an important endpoint for patients, can reduce exacerbations by up to 50%, reduce hospitalization, and may also allow reduction in the dose of inhaled corticosteroid and oral corticosteroid if the patient was on oral corticosteroids. This medication is given by subcutaneous injection every 2 to 4 weeks. Usually we start with a more frequent administration, then can stretch this out over time. And this medicine is now approved for children 6 and older, as long as there's demonstration of a positive skin prick test or serum test for allergic sensitization, and as long as we have measured and elevated IgE within a certain range. Side effects of this medicine would include the potential for anaphylaxis and inflammation at the site of injection. And because of the anaphylaxis risk, in the vast majority of cases, this medicine has to be administered at a medical site. So it could be a physician's office in a hospital, and there are certain injection sites in different communities as well where this medicine can be given. The next type of biologic medication that is also now available for children, which is quite exciting, is mepolizumab, trade name Nucala. And this medication targets IL-5. If you recall, those white blood cells called eosinophils, among other things, produce a molecule called IL-5, which gives rise to inflammation. And the job of mepolizumab is to stop that IL-5 from causing inflammation. And if an individual has high serum eosinophils, they may be a candidate for this medication. So far in adult studies, this medicine has been shown to reduce exacerbations as well as oral and inhaled corticosteroid use and can improve lung function and quality of life. It's given by a subcutaneous injection every 4 weeks. For children 6 to 12, this injection has to be prepared and mixed, so it would be given in a traditional syringe. But for older children, 12 and above, I believe, it can be given in a pre-mixed auto injector. So this device that I've shown on the screen here. And I believe it can be even administered once safety has been demonstrated by the patient in their own home. So it helps to make this more available for families too. Now, side effects of this medicine that have been reported include rhinosinusitis, headaches, and so far there's been no anaphylaxis reported. It's a new medication, but this is quite promising. In the same category, there are a few other anti-IL-5 medications. One is called reslizumab, and I apologize, I didn't have a chance to look up whether this is currently available in Canada. It is currently only available for adults, but it's worth mentioning just to give you insight onto newer medications that are constantly now being developed again, which is quite exciting for kids with severe asthma. This medicine has been shown to reduce exacerbations and improve lung function. It's also given by a monthly, in this case, intravenous injection, and has been reported to have some side effects, upper respiratory tract infections, sinusitis, headache, and potentially anaphylaxis, but it may be an option for some patients in future. Again, along the same lines, another anti-IL-5 medication is benralizumab, which is not yet approved by Health Canada, but again, just to give you an idea of the new medications that are being developed and may become available over time. And then the last in this class of biologics I want to speak to today is dupilumab, by trade name Dupixent. This is a slightly different biologic as it targets IL-4. So IL-4 is another cytokine or inflammatory molecule that is produced by these eosinophils. And this medication blocks that inflammatory response. It also comes as an auto-injector, as you see here. And in studies in adults has been shown to improve lung function, reduce exacerbations, and reduce oral steroid doses. It's been approved for asthma by the FDA in the United States since 2018. It has recently been approved for an indication of atopic dermatitis or eczema for children 12 years and older. And I think very soon, within the next few weeks, it's expected to have an indication for asthma in this age group as well. So just to finish up, we mustn't forget, in addition to all these medications, there's always other strategies to treat even people with severe asthma, even people who've had asthma for a very long time. Education is still a cornerstone of management. It's surprising how, after many years, the technique for correct use of inhaled medications can wane. People can take shortcuts over time, so it's always a good idea to revisit that. Avoiding and thinking about what triggers may be exacerbating asthma is always important. And as the children get older or as life changes, there may be occupational exposure. So adolescents who have summer or after school jobs, different childcare facilities or secondary family homes may have allergens or irritants present that weren't there before. And it still surprises me how many people I recognize, they may be very attached to their pets, but we must continue to work on removing pets if people actually have allergies to them and we believe it's affecting their asthma. And finally, I wanted to touch on the importance of an asthma action plan, which, when combined with asthma education, is shown even in children to reduce morbidity. And this here is just one example of an asthma action plan that's been developed by the Lung Health Foundation in Ontario, using the best evidence that we have available and a multidisciplinary approach to its development that included different physician and other care provider specialists who treat children with asthma, as well as patients and families, to ensure that it's easy to understand and easy to use, and was felt to be helpful. And it uses the traffic light symbols. Green, or go maintain, means asthma is well controlled, but lists the types of medications that should be used on a daily basis. Yellow means asthma is starting to get out of control, and red means danger zone and get help right away. And on the back of this asthma action plan are some education items. So identifying and avoiding triggers, simple ways to take care of your asthma, enforcing adherence here. And there's a little bit of education intended for primary care on how to diagnose and initiate asthma treatment for children in the preschool age category who may have asthma. So with that, I'll finish off and open up to any questions.
Thank you so much, Dr. Radhakrishnan. I do have a couple of questions here. So I think what we will start with is I have a question from Laura. So Laura asks, what is the best treatment for severe asthma in a 3-year-old already on 500 to 600 QVAR daily and Singulair? All the options seem to be approved for ages over 6.
So that's an excellent question. And now we're getting into the realm of off-label use. As of today, none of the biologics would be used, I think, by the vast majority of my colleagues, including myself, under age 6. It would be exceptionally rare circumstances that we'd consider. Similarly, for tiotropium, it's provided in a delivery device that's very difficult for young children to use. But there is a class of medications, the combination long-acting beta agonist with inhaled steroid, that it would be off-label use in children under the age of 6, but in rare circumstances, we do sometimes, with very close monitoring, off-label and having a good discussion with the families, try these inhaled steroid LABA combination medications, even in younger children, and sometimes can get some good response.
Okay, thank you so much. So our next question comes from Andrea, who asks, how do you monitor for side effects of asthma medication for children with severe asthma?
That's an excellent question, Andrea. I'm going to get to your question in half a moment because I saw the previous person had added a follow-up question. I just want to address that. They had mentioned that this child had been started on Advair, which is an inhaled steroid LABA medication, and lost her voice, which can be a side effect of certain medications. I would advocate strongly in the case of this child that probably specialist care is warranted. We have a nice network of respirologists across the country, and we do sometimes discuss difficult cases amongst us. And if you're able to tap into that network by a referral to a specialist, there may be other treatment options available that are perhaps out of scope for the moment. Though I'd be happy to have further discussion offline. In response to Andrea's question, how do we monitor for side effects? Well, the biggest side effect that I wanted to talk about is really adrenal suppression. And our children with severe asthma are definitely at risk, because if they fall into the category of severe asthma, that means they are on high dose of inhaled steroids or on oral corticosteroids. So most of them would be on high-dose inhaled steroids. And just recently, the Canadian Pediatric Society published a statement that was developed in coordination with respirologists, endocrinologists, and other people who treat childhood conditions using steroids, to say that kids who are on high-dose inhaled steroids should have screening for adrenal suppression through a morning serum cortisol test done at least once per year. And that was just a little nugget I wanted to leave with the audience, that it's important to look for side effects that may not be immediately apparent or symptomatic, and in certain cases, we have to screen. Other things for children who are on oral corticosteroids, it's important to screen for blood pressure, blood glucose monitoring, and even bone health through bone densitometry, and sometimes coordination with endocrinologists and with bone health specialists, depending on the specific patient situation.
Perfect. Thank you. Okay, I think we'll move to Danielle's question. And Danielle asks, what's the most important thing for a parent to a child with severe asthma to know?
What's the most important thing? That's a tough one because I'm not sure if I can necessarily boil it down into one. Um, Perhaps to know that, from my perspective, in partnership with your healthcare provider, your child could achieve, even with severe asthma, a normal and healthy, active life. That's probably the goal that we should all keep in mind as we're trying to manage our young patients with asthma. If you feel that with your healthcare provider, you're not quite achieving that goal, my advice would be to request participation by asthma specialists and other providers in partnership with your primary care provider to achieve a good treatment plan and monitoring for your child so that they can achieve that goal.
Perfect. And Danielle also asked another follow-up question, which was, how frequently should I take my child with severe asthma for an asthma checkup?
That's a great question. For any child with asthma, our bare minimum would be a checkup once a year, specifically to talk about asthma and asthma control. But beyond that, I would say for most children that I follow who are on higher doses of medications, I would try to see that child at least twice a year, and that's specifically to monitor growth and look for these more subtle side effects with use, higher dose of medications and off-label medications. But it really depends on the severity of the child, the frequency of their exacerbations. Ideally, they should be assessed every time there's an exacerbation, every time there's a change in the level of asthma control. So if you have an asthma action plan and the child is not really meeting the goals in the green section of that action plan, that warrants setting up an appointment with your care provider to see what can be tweaked about their treatment plan.
So our next question comes from Michael, who asks, what are the different types of lung function tests used to diagnose severe asthma?
So, the most important type of lung function test that we rely on is just regular old spirometry. So, measuring this value called forced expiratory volume in 1 second, or FEV1. And the name for that type of test is spirometry, both before bronchodilator and then after bronchodilator to see if there's reversibility. But sometimes that test can be normal, even though the child has asthma and even though they have a history of exacerbations and may even fall into the category of severe asthma. So in those cases where there's a diagnostic challenge, then we move on to a test called a methacholine or other types of what we call bronchoprovocation testing. So sometimes that would be an exercise induced spirometry test to see if we can mimic the symptoms and the bronchospasm that the child may experience with exertion. And the methacholine test would be to mimic the symptoms a child experiences when exposed to allergens in the environment. Sometimes, to be more thorough, and if we're worried that we don't have the right diagnosis, we may also do lung volume testing. So that would be the 2 or 3 types of lung function tests that we use, typically in kids 6 and older.
Perfect. So our next question comes from Mark, which is, how do you decide which biologic medicine to use in a patient?
Right. So again, the use of biologics or some of these more new and specialized medications really pertains to a small group of people with asthma, even a small group within the severe asthma population. But the first step is to take a good history and make sure we're identifying all the triggers and things that could be exacerbating asthma, making sure they're adherent, all of that. But then we would do a phenotyping exercise. So we would get the allergist involved, make sure the child has had allergy testing to see if they fit that allergic profile or not. And we do blood tests to see whether they have elevated immunoglobulin E and whether they have elevated eosinophils. And then putting that all together, we would choose the right type of specialized asthma medication to provide the child. Based on that profile, we would make a guess as to whether they likely have a Th1 type of inflammation or a Th2 type of inflammation, and then choose the treatment plan accordingly.
Perfect. I think that actually reaches, I think we've addressed all of the questions. If we haven't, please do type in and I'll make sure I will get to yours. And if not, you can always reach out to info@asthma.ca as well, and we're happy to connect and coordinate that information for you. Okay, I'm not seeing any more questions, so thank you so much, Dr. Radhakrishnan. Those were some good questions and hopefully helpful for the entire audience as well. So we're pretty much at the end of our time. So thank you again. We really appreciate you taking the time to give us this presentation, and thank you so much to everyone for attending. If you've benefited from our webinar series and would like to see similar programming, please consider making a donation at asthma.ca. And like I said, if you have at any point any further questions or something comes to mind later, don't hesitate to email info@asthma and we'll be happy to help. All right, I think that's the end of our presentation. Thank you so much.
Thank you very much. It's my pleasure.